Start our presentation. Thank you so much for joining us. Welcome everyone to the Women Heart National Hospital Alliance webinar on migraines and heart disease in women. I am Elaine Vining, Senior Director of the National Hospital Alliance at Women Heart, the National Coalition for Women with Heart Disease. The National Hospital Alliance is a partnership between Women Heart and hospitals around the country committed to gender-specific cardiovascular care to advance education and support for women heart patients and women at risk of heart disease. I want to begin by saying a very gracious thank you for you and your time, your energy, and commitment to helping women around the country with or at risk of heart disease. We all know that it's the #1 cause of death in women, and this collaboration between Women Heart and hospitals to engage clinicians, patients in the community in raising awareness, expanding education, and sharing support will help us all change the trajectory of heart disease in women. We are very pleased to have a distinguished presenter today from NHA member Norton Healthcare in Louisville, Kentucky. Dr. Brian Plato is the Medical Director of Headache Medicine in the Norton Neuroscience Institute of Norton Headache and Concussion Center. Dr. Plato is going to discuss migraines as a prevalent disorder that are increasingly recognized as a risk factor for cardiovascular disease in women. This webinar will last approximately 60 minutes, and we'll have a question and answer session in the last approximately 15 minutes of the webinar, so you can ask our presenter any questions you may have. Once we reach the Q&A portion of the webinar, I will give you instructions on how to submit your questions. Dr. Plato will answer them in the order in which we receive them. So without further ado, let me turn it over to Dr. Brian Plato, who will start the presentation. Thanks, Dr. Plato.
Yeah, can everyone hear me now? Good. I hope so. So my name is Brian Plato, and I am a neurologist here in Louisville, Kentucky. And so I appreciate the invitation to speak this afternoon about a topic that I think many people who are in the world of cardiovascular medicine and doing things in heart disease prevention may not be aware of the prevalence of migraine and how it may influence cardiovascular disease evaluations and risk factor stratification. So I'll be talking this afternoon a bit about what migraine is, helping understand the background of migraine, and then putting together some information about what people might want to think about in terms of evaluating specifically women who may be at higher risk of developing heart disease. So we can go ahead and get started. If you can move to the next slide, please. So why migraine? Why should we care? And the reason is that migraine is a common disorder. So worldwide, migraine is the 3rd most prevalent disorder and is the 6th most disabling disorder worldwide. Nearly 20% of women have migraine, and oftentimes it's overlooked. Okay, so I think a lot of clinicians and individuals with migraine themselves may not be aware that they actually have a diagnosis of migraine. And a couple of important things there are, one, what we'll talk about here in a few minutes is how that might actually augment their risk factors for developing other diseases, specifically cardiovascular disease in the future. And then also that there might be something to do about it. Something that I'm constantly amazed by is how many people will have frequent disabling headache and don't really seek medical attention for it. I think that there are a lot of reasons why patients are not seeking medical attention in regards to disabling headache disorders. I think some of those have to do perhaps with the medical community maybe not fully understanding the importance of these diagnoses, or patients who have sort of been frustrated by not making progress in improving them. And so it's just sort of something that many times they sort of learn to live with. As an example, a patient I just got done seeing before this has had more days with headache than without for at least 20 years, and she really hasn't seen too many people about it. And this was really her first time seeing a neurologist and seeing a headache specialist. And so there are a lot of things that I think really can be done to improve the quality of life for these individuals. And then, again, specifically identifying what other risks or other medical problems that should be aware of. So I think sometimes people put it off as just bad headaches, or a term that I hear a lot here in the South is this term of sick headaches. I think many times that applies to older generations. So people will say, when asking about family history, oh, my grandmother had, sick headaches. Sinus headache we'll talk about. And then I think a lot of people just sort of think, oh, it's just because I'm stressed or something like that. And so it's not something that, really should be thinking about. So let's move on to the next slide. So the question is, what is migraine? So migraine is a brain disease. It's a neurological disorder. So we need to think of migraine as a brain disease, and we need to treat patients and educate them on the fact that they have a brain disease. They have a neurological disorder. So I think many of us were taught in medical school or in other educational forums that migraine was this problem where blood vessels were constricting and dilating, and that's what caused the problem. And that is not the case. So those changes in vasodilation that occur are actually secondary to what is happening during migraine, specifically the release of something called calcitonin gene-related peptide that results in this vasodilation. So we shouldn't just think of migraine as like this blood vessel disorder. We should think of it as a problem of the brain. And I think the other thing that I'd like to highlight here is that migraine is not just a headache. Okay? So headache is one of the symptoms of migraine, but there are so many other symptoms that accompany migraine, including light and sound sensitivity, nausea, vomiting, difficulty concentrating, many times changes in vision, numbness, trouble with language, all of these other neurological symptoms that can accompany a migraine attack, which I think gets back to the idea of it being a brain disorder and really shouldn't be just thought of as like a really bad headache. So, so moving on to the next slide, please. How do we diagnose migraine? So, so migraine is a disorder that there is no currently available blood test. An MRI scan doesn't show migraine. It is a clinical diagnosis. It means sitting down, asking questions to a patient, letting them answer those questions, and then synthesizing that information into a diagnosis. So, but what I think should be remembered is that in the setting of primary care, people coming in with the chief complaint of headache most commonly will be diagnosed with migraine. And so when I'm teaching people in primary care of how to manage migraine, I many times, sort of try to teach them of learn to identify what migraine is, what the symptoms are, what things people with migraine talk about, so that then you can sort of learn that as the reference point, and then things that fall outside of that are things that, we might want to look at, a little bit closer. And then this other one is particularly here in the Ohio Valley where I live and practice. All the time I get people who come in and say, oh, I just have sinus headaches. And if you move on to the next slide, you'll see that the reality is that most people with self-reported sinus headache actually have migraine. So, as a bit of a, sort of freebie, if a patient came into clinic and was telling you about their sinus headaches, I would sort of turn my attention in questioning to be more in line with migraine to, perhaps more properly diagnose them. And then moving on to the next slide, if you look at a population of patients coming into primary care, you can see that about 94% of patients who are seen in primary care with the chief complaint of headache have a diagnosis of migraine or migrainous headache or probable migraine. So, I think in the primary care setting, not that we want to always be thinking one way, but I think statistically speaking, most often you're going to be coming to a diagnosis of migraine. So get familiar with what the characteristics of migraine are, get familiar with how to diagnose it, and then, like I said, when things sort of fall outside of that, then maybe we can start looking at other disorders. So the next slide reviews the classification criteria for a diagnosis of migraine. So we use the International Classification of Headache Disorders, and what we're looking for is two of the following four. So one-sided, throbbing, moderate or severe, worsened by or causes the avoidance of physical activity, so two of those four things. And then one of the following, light and sound sensitivity, nausea and or vomiting. And then this can be with or without aura, which I'll get to here in a second. So, I think that I remember in medical school, there was sort of this like picture of migraine being like shaded in on one side and tension type headache being shaded in on both sides of the head. And the reality is that not one of these specific characteristics makes the diagnosis. So, you can have a moderate or severe headache that causes you to avoid physical activity with nausea, and you've fulfilled the criteria for a diagnosis of migraine. So it's not necessarily just focusing on where it hurts or how it hurts or things of that nature. So these are the diagnostic criteria, things that I would become familiar with and sort of tailor questioning of patients to these collection of symptoms. So moving on to the next slide, discusses what aura is. So aura is transient neurological symptoms that are fully reversible that occur in up to about 30% of patients with migraine. They do not occur necessarily with every migraine attack. So patients who have migraine with aura may at times have migraine attacks that include aura, and at times those that do not. Most patients who have migraine aura have visual symptoms, but can also include sensory symptoms, so numbness that sort of creeps up the arm into the face, language problems, so difficulty coming up with words to use or constructing sentences. They may have some weakness, they may have some off-balance feelings, they may have dizziness, they may have vertigo. Symptoms last between 5 and 60 minutes, and they typically precede the onset of headache, but they can accompany it. And these symptoms tend to occur one sort of right after another, and that has to do with what is happening in the brain, and I'll show that here in a minute. So if we move on to the next slide, what is happening on a physiological level with migraine aura is something called cortical spreading depression, which really is just sort of this like intense depolarization of brain cells that typically begins in the occipital lobes, which are in the back, which are responsible for visual symptoms, and then moves forward. And so if you move on to the next slide, you can see there's a phenomenon that was called the spreading depression of Leao, which is shown here, where there is this sort of spreading depression of cortical activity electrically that moves from one location to another over time, and so that activity of the brain is depressed, and then after a period of time returns, and that's what accounts for the sort of migration of these symptoms and then them returning. And this is something that I think is really important when you're evaluating patients with aura, because I'll talk about later on how sometimes a diagnosis of a TIA could be confused with an episode of migraine aura. And one of the things when I'm evaluating these patients that I'm asking about is sort of how did the symptoms evolve? Was it just sort of all of a sudden they developed these symptoms? Or was there sort of this, migration of symptoms that sort of started in one location and then moved to another location, like I said, maybe migrating up the arm and into the face, or starting with visual symptoms and then the sensory symptoms. And so asking those questions has relevance in terms of what is happening physiologically, and I think can help make a diagnosis. So in the next slide, we're talking about how to take a headache history, because maybe that's not something that we're typically doing. So as I said, we want to find something that is consistently a reliable and efficient way to diagnose these patients. So as I said earlier, those ending up in primary care most probably will have a diagnosis of migraine. So let's get really familiar with how to diagnose migraine, and then we can sort of think about other things for people who do not necessarily have those typical features of migraine. So the next slide shows something called ID migraine, which is a 3-question screener that really could be done by a medical assistant or a nurse or whoever is sort of getting these patients into a exam room and sort of taking the initial history depending upon what the clinic setup is like. But 3 questions. This takes maybe 20 seconds to ask. So in the last 3 months, did you have any of these with your headaches? You felt nauseated or sick to your stomach? Light bothered you more than when you don't have headache? And your headaches limited you from being able to do work, school, or what you wanted to do for at least one day. So yes to 2 of those, 93% probability of having migraine. Yes to all 3 is pretty sensitive for a diagnosis, or specific for a diagnosis of migraine. So now I'm not saying that these 3 questions should absolutely replace a full history and physical, but I think what it does is it helps sort of frame where the questions should go, because I know many times in primary care situations, there's only a few minutes that you have to really spend with the patient, and so this might help tailor the conversation. So if you can advance the slide, please. So the bottom line is that these patients are in your practice. So in primary care, I would make sure to be asking about patients who have recurrent bad headache. In the OBGYN situation, asking about females who have headache with menstruation. In the ENT office, the sinus headaches. I think in pain management, a lot of times patients who have a lot of neck pain and perhaps a diagnosis of fibromyalgia may have comorbid migraine that may or may not be undiagnosed. And then in cardiology, as we'll talk about, females who have premature heart disease, I think this is something that is worth screening and talking about. So move on to the next slide, please. So the overlap between migraine and stroke kind of came about in the 1970s, and since that time, there have been numerous studies that have identified that there is a risk of stroke with migraine that is independent of oral contraceptive use. And I'm not going to get too much into oral contraceptive use. That is maybe something that could take place at a later seminar. But the bottom line is that it appears as though migraine is a risk factor for stroke. So moving on to the next slide, please. So the difference between migraine with aura versus migraine without aura. So it looks like migraine with aura is consistently seen as an independent risk factor for stroke, whereas migraine without aura has really not been shown to reliably be a risk factor. And if you put the two together, it does look like all migraine is, but I think you would presume some of that is due to the inclusion of migraine with aura. So the next slide, please. In the correlation between migraine with aura and stroke, it looks like a lot of these studies, the risk is in women who don't really have other your typical cardiovascular risk factors. In the Women's Health Study, the risk of stroke in migraine with aura was seen in those who had low Framingham risk scores. They were younger, they had low total cholesterol levels. And so I think as we talk more here, this is something that, when I'm seeing, an 18, 19, 20-year-old female who I diagnose with migraine with aura, who really has no other medical problems, let's say, I'm at least bringing this up, not to sort of scare them off, but more to say, look, this is something that is different about you, that changes your overall risk factor for diseases like stroke, and as such, you should be perhaps more in tune with this than other 18 or 20-year-olds are in terms of managing those other risk factors like hypertension, cholesterol, and then if you move on to the next slide, smoking really seems to be a big one, which I'm sure everyone on the line is definitely in agreement that smoking is bad. So the risk of stroke is increased in women who have migraine with aura without those traditional risk factors, but smoking really increases that risk even further. And the combination, it appears, of migraine with aura and smoking really increases the risk, particularly if you add in an oral contraceptive to the mix. So, the bottom line is, when I'm seeing these patients who, again, are 20 years old, no medical problems, they have migraine with aura, I'm sort of sounding like that old guy that is, really saying to them, you shouldn't do these things, but now I actually have, a reason to say they should not be smoking other than just because, as all patients think, all doctors, always are telling patients they shouldn't smoke. But you can say, look, it really looks like this risk further increases, and so this is really something that you should either stop or be certain to avoid. So move on to the next slide, please. So the risk of TIA, as I said earlier, TIA is transient ischemic attack is a clinical diagnosis, and migraine with aura is as well. And so I would say not uncommonly we will get consultations in the hospital for, a 30-year-old female who's coming in with some, transient neurological symptom, and you're having to decide whether it was a new migraine with aura event or TIA, and so it can be difficult to differentiate. And so I think that it's a bit difficult to really study this, but it does appear as though back to the increased risk of stroke, women who have migraine with aura also have a higher risk of TIA. Moving on to the next slide with the risk of hemorrhagic stroke. In terms of hemorrhagic stroke, it does look like migraine is associated with an increased risk of hemorrhagic stroke, both intracerebral hemorrhage as well as subarachnoid hemorrhage. And there really is not great data to differentiate migraine with aura and migraine without aura, but nonetheless, it does appear as though there is an increased risk of hemorrhagic stroke. Next slide, please. So in terms of heart disease specifically, in terms of the risk of MI, it does look like there's an increased risk of MI with migraine with aura, but not migraine without aura. And it looks like individuals who have migraine with aura have a higher risk of angina. But it doesn't look like there's necessarily an increased risk of ischemic heart disease mortality with migraine. So, I think that, in the cardiology, either unit of the hospital or cardiology clinic, when some of these younger patients are coming in who don't necessarily look like the typical patient who's coming in to that clinic, younger, generally healthier females who may have had an MI or have angina. I think of course, being a headache specialist, I'm going to say this, but I think that, these studies will suggest that, these are questions that probably should be screened for, and then if identified, perhaps sent over to the neurology department. So if you move on to the next slide, the questions are, why does this happen? What is the link here? And I think that the reality is that it probably is a multifactorial link. Okay, so maybe not necessarily one thing. So one thing would be is commonly used medications to treat migraine are NSAIDs, and I think that it looks like there's an increased risk of cardiovascular events with NSAID use. So perhaps it has a component of medication use. There are elevated inflammatory markers in individuals who have migraine with aura, perhaps due to endothelial dysfunction. What about lifestyle factors? So people with migraine sometimes may have reduced physical activity because they either have migraine triggered by exercise, or they sometimes will avoid regular exercise routines due to the frequency of migraine that they have. Exercise may be a trigger for migraine, with alcohol being a trigger for migraine. People who have migraine may have reduced alcohol intake. There may be some genetic factors that coexist between migraine with aura and cardiovascular disease. Patent foramen ovale is more prevalent in people who have migraine with aura and may be a contributory factor. There is an increased risk of cervical artery dissection, so carotid and vertebral artery dissection in individuals who have migraine with aura, which increases the risk of stroke as well. So, I think that there are several things to think about. And so if you move on to the next slide, the question is, well, what does this all mean? I think what this means is that there is clear evidence that the risk of cardiovascular disease, particularly cerebrovascular disease, is greater in patients who have migraine, particularly aura, but it's still a pretty low risk. So I added this in because I don't think that we need to necessarily be sort of sounding the alarm to every young female who comes into clinic, because the risk of stroke in young women is pretty low. I put this in, found a statistic that the risk of being struck by lightning is actually higher than the risk of stroke in these younger women. So even though migraine with aura confers about a 2 times increased risk of stroke, it still is a small risk. But I think it is something that if we can have a reason to open up the conversation about risk factor stratification or risk factor modification in people who, I think most 20-year-old females aren't really thinking about hypertension and smoking and their cholesterol levels. And so I think that this at least opens up that conversation as to, why they may want to think about these things. So please go to the next slide. So what should we do? So it doesn't appear as though medical therapy is necessarily recommended for the primary prevention of vascular disease in patients who have migraine. So aspirin or other antithrombotics should not necessarily be given for primary prevention. So PFO is a pretty controversial thing. I think that there's a lot of back and forth in the literature right now, but PFO is more common in patients who have migraine with aura, but closure of PFO specifically for migraine with aura should not be recommended. And although there is no direct evidence that preventative treatment of migraine equates to a lower risk of cardiovascular disease, there does appear to be an association between the frequency of migraine aura attacks and cardiovascular disease risk. So maybe there is. And, I think that would be perhaps justification for screening patients and, getting them seen by neurology or headache specialists if available in your region to help reduce the frequency of these attacks. One, just to improve their overall quality of life and reduce disability associated with migraine, but maybe there is an association. So go on to the next slide. So oral contraceptive pills, I said I wouldn't go too much into this, but just briefly looking at this. There is no real consensus between different professional organizations about what should be done. I think that non-smoking women who have migraine with aura, estrogen-containing contraceptive products should not be an absolute contraindication. I think that having a conversation about how some of this data is not entirely clear, should be had. But certainly, if women are started on estrogen-containing products and either start having aura or the frequency of aura increases upon starting those products, then I think that it should be discontinued. And I think that women who smoke who have migraine with aura should not be given estrogen-containing oral contraceptive pills. That is my opinion there. Move on to the next slide. So what do I do? So a lot of these patients who are coming in to see us don't really have a lot of other medical problems. And so even though, the 18-year-olds roll their eyes at me, I do use this as an opportunity to talk to me about, lifestyle changes, smoking, generally leading a healthier life with exercise and better diet. And I tell patients that they have a disease that changes their overall risk for vascular disease, and that they should use it as an opportunity to reduce other modifiable risk factors. So I think I've left plenty of time for a Q&A session. So I've included my email address if there are things either afterwards that you want to talk about. So if you move on to the next slide, it shows my email there. Or I think they have a mechanism set up here that questions can be asked. So please ask away. We've got a bit of time, or send an email afterwards.
Thank you, Dr. Plato. This is Elaine again, and we are grateful for that great presentation. This actually does start the Q&A portion of the webinar in these last 15 minutes or so. So I wanted to share with folks online how to connect and submit questions. So let me walk you through this. In the upper right-hand corner of your screen, you'll find a rectangular box that contains various icons known as the Grab tab. And if you locate and click on the orange arrow icon at the top of the Grab tab, you can expand your control panel. Find the pane that is labeled Questions in the bottom half of the control panel, and you'll see a box containing the words Enter a Question for Staff. This is the box where you need to submit questions. If you don't see the box underneath that Questions pane, click on the arrow next to the word Questions and the box will expand. Just type your questions and click Send. It'll automatically come to me and will not be seen by anyone else. I'll read the questions out loud. in the order I received them, and and then Dr. Plato will answer them in that order. So you can ask as many questions as you like. We'll give it a couple minutes to start the questions, get folks through that process. Don't forget to click submit. But as people are asking their questions, Dr. Plato, I actually have just a follow-up question to one of your last slides. You mentioned that the frequency can be have predictive nature, but does the severity of a migraine or the age of onset predict the risk of heart disease in women at all? Or do we know?
I think it's a good question. I think the severity of attacks, so by that I think what you're really asking is the pain severity, right?
Right.
And so there's no evidence that I'm aware of that the severity of the attack in terms of pain or even the severity of other coexistent symptoms necessarily correlates to the risk of vascular disease in the future. In terms of age of onset, again, I'm not aware of any data that specifically says a younger age or a later age of onset does necessarily correlate. I think that what I would probably pull out of that is that people with sort of a younger age of onset are more likely to have a higher frequency of cumulative events than those who have a later onset, but I don't think that there's any evidence that that is, a clearly identified thing. A lot of these studies are hard because they are, large populations of, so studies of large populations of individuals that are followed over time. And, I don't think that necessarily an opportunity is given to sort of delve into all of the questions that, someone like a headache specialist is going to be interested in terms of, just how often are they having attacks and, what are the correlating symptoms. Just getting a diagnosis out of, some of these populations of migraine can be a tricky enough thing.
Good. Good. Thank you. Thank you for that. And actually, we have a question from one of our attendees. Is there one particular symptom of migraine with aura that you or researchers have seen associated with stroke? So
almost all patients who have migraine with aura have visual symptoms. Again, because of where it's coming out of generally with the occipital lobes, most are going to have visual symptoms. So most are going to, I think most people are going to say visual symptoms are included because they tend to have those. I don't think that there is one specific symptom that if they have it, that likely corresponds to a higher risk of stroke. I think one thing that I did not touch upon this at all in the presentation, but there is something that is called a migrainous infarction. So this is an event that begins like one's typical migraine with aura event, but then actually turns into an ischemic stroke. And so, those individuals will have sort of the onset of their aura symptoms, and they persist for a prolonged period of time, and then they're found on MRI to have actually had a stroke in an area of the brain that corresponds to that specific symptom. But I don't think that you're going to find that, there's like one specific symptom that, is more likely to, let's say, increase or decrease your risk stratification.
Good. Thank you so much. We've got actually a two-part question from Kim Schneiberg. How many headaches with aura per year or month are associated with increased risk of stroke and or heart disease? And the second part of the question, I can repeat it after you answer the first part, But the second part is you talked mainly about an increased risk in young women. Is there a higher risk over age 50 based on migraine with aura? So however you want to...
The second part of that question first is that that most of this data is pulled from younger patients in whom there are typically not those other coexistent risk factors that may tend to pick up later in life. And so in terms of older individuals, and I think older becomes relative somewhat in these conversations, but there's not, as far as I'm aware, any specific data suggesting that at an older age these rules necessarily still apply or are further increasing that risk. So it is generally pulled out of younger patients below the age of 50 that increased risk exists for. And then the first part of your question was about the frequency of aura, and so so frequency would be those who have aura that occurs less than once a month would be a lower risk stratification, perhaps, and then those with it occurring more than once per week would be at a higher risk stratification. I'm trying to pull up that reference because I'm thinking that is correct off the top of my head. I just don't have it right in front of me, but I think that it's less than once per month being lower, and then more than once per week as being higher risk.
Okay, terrific. Another question from Sandy Kriz. What causes, or what she calls, a cluster aura? She said, I get them every 2 or 3 years over a couple of days to a week, and then they're gone. In her last episode, the aura transitioned into a migraine. What changed?
So probably your age changed. So first of all, so you can, and this is not something that I talked about, but what you said was basically asking about aura without headache. So again, getting into the idea that migraine is not just this headache problem, is that migraine, you can have migraine aura without any of the headache symptoms, and that sometimes gets really tricky to diagnose when someone comes in and they had, let's say 30 minutes of vision loss in one eye. Gosh, that can sometimes be tricky to diagnose. So many times those are diagnoses that are made after exclusion of other things, or many times when it happens in a stereotyped fashion. So what I mean by that is someone comes in and says, for the last 10 years, once a month I get this 30 minutes of vision loss, and a touch of numbness, and then it goes away. In my mind, the more that these things happen, it might make it easier to diagnose that it's not something more ominous, and that's not a steadfast rule. Now, in terms of what you're calling a cluster aura, so I think really what you're saying there is that you will have times where you have aura that occurs back to back to back, maybe on successive days, and then you don't have anything for other periods of time. And there really is no answer as to why. Many times these things are sort of like a summation of triggers. So, it may be that, at that particular time, there's a barometric pressure change combined with some change in your hormonal status with your monthly cycle, combined with a poor night of sleep, and that sort of triggers an attack, and then many times you'll find that after people have had one attack, they are a bit more susceptible to having other attacks sort of around that time, maybe back to back. So I think it's just sort of like you've primed the system with whatever collection of triggers there were, and to be honest, it's probably going to be difficult to identify a single trigger because many times it is, sort of this cumulative effect of them. And then why you had headache that followed it, just because sometimes that's the way it goes. I mean, there's not really a better answer that I can give you other than that. I think, the thing that changed, as I said, was, sort of over the life of someone with migraine, you will see an evolution. So the migraines they had as a teenager are different than the migraines they had in their 30s and are different than the migraines that they have in their 50s. And some people continue to have migraine well into, later life. I, have patients in their 80s and early 90s who still have migraine. So it does not always get better postmenopausally as, some people say.
Thank you. Another question, it's from Rita Ray, who asked, are migraines hereditary? So if she suffers from migraines, how likely will her daughter, or I guess son, suffer from this as well?
Right, so definitely there is a genetic component of migraine. So so the real answer to that is it depends upon who you had as the father of the children. So with one parent having migraine, the risk of children having migraine would be 50%. With both, it would be more like 75%.
Okay. Let's see. Last question. Let's see. Kim Schneiberg sends a note. Have Triptan medications been associated with increased risk of stroke?
So there are reports of triptans associated with stroke. With their acute usage, not the. So you may be asking two things there. So you may be asking, does taking a triptan during a migraine attack, and for those who may not be familiar, triptans are medications that are used for the acute treatment of migraine. They can be associated with a slight vasoconstriction of blood vessels. Study a couple of years ago demonstrated that the vasoconstriction that occurs with injectable sumatriptan occurred with extracranial, so outside of the brain blood vessels, but not intracranial blood vessels. We believe their site of action is outside of the brain. So I think you might be asking two things. So question A you might be asking is, does taking a triptan during a migraine increase your risk of having a stroke with that singular event? The question two that you might be asking is, if I've been taking triptans a couple times a month for the last 10 years, am I at an increased risk of having a stroke? So the answer to hypothetical question number two is no. It's not a cumulative, risk with those. With question one, or what I suggest is question one, it is that they have been reported with their use to induce cardiac events. And then with stroke, I think, I talked about a thing called migrainous infarction. I think that, it might be difficult to decide whether to call it a migrainous infarction or induced by triptan, because as I said, the triptans don't really cause an intracranial vasoconstriction. So I hope that one of those two were in line with what you were asking.
Well, thank you, Dr. Plato. I think we are actually just about out of time, and I want to thank you for a terrific webinar and wonderful information that's been shared. I also want to thank everybody who attended the webinar today. If you have any additional questions, Elaine Vining's email will also be in the follow-up email you receive tomorrow around this time. Also in that follow-up email you'll receive tomorrow will be a link to the webinar recording in case you want to watch it again or share it with any of your colleagues. Also in the follow-up email will be the link to the slides from this webinar. So again, Dr. Plato, thank you so much for your time, and to Norton for co-hosting this webinar with the National Hospital Alliance of Women Heart. Dr. Plato, any parting words?
No, I would just say, I think the more that you are aware of migraine as a disorder and are evaluating patients for it, I think that they will be appreciative of someone listening to them and helping them with a disorder that many times is overlooked. So thanks for having me. I enjoyed the conversation, and have a nice day.
Wonderful. And I want to thank everyone again for their time and their great questions. We hope this was helpful, and we welcome any feedback. So this concludes our webinar, and thank you again. Bye now.